Oh, hey,
Hello?
Aaron, can you hear me?
Yes, I can hear you. Can you hear me?
Yeah, no, you're fine, man.
Wonderful. Alrighty, and I'll just do a test on the slides. Are the slides changing?
Yeah, everything's going all right on my side as
Nice
well.
one. Yeah, I'll get started if you wouldn't mind just queuing some of the polls for the questions.
Yeah,
Dr.
absolutely. I can
Five,
do some right now.
thank you so much. Hello, good evening. Thank you for waiting. Welcome to MedTic's weekly Road to Final series. This week we've got a bit of a mix of rheumatology and dermatology by myself, Dr. Aaron, and Dr. Yi. We'll be taking you through 10 high-yield questions, each with a key learning point, and as well just a little bit of teaching about each of the conditions that we cover. Yeah, right. If there's any questions or any queries, just put them on the chat, and we'll endeavour to answer them. Should take about an hour. After which we'll stay on for a couple of minutes for any further questions. Right, let's get started. So when we had a look at the MLA content map, I think we just wanted to combine rheumatology and so we extracted, these are the conditions that we're going to hopefully try and cover. And at the end of these slides, there's a big list by Yi in terms of what things came up or were particularly high yield in last year's MLA. So that's right at the end. Right, so let's get started. So question one, I'll read them out and I'll give you a couple of minutes to put them on the poll. 45-year-old male presents to AMU with a unilateral painful knee. On examination, it's red, hot, and swollen, and the pain is worse on movement. He denies any fevers or systemic symptoms like general malaise. He's tried paracetamol and ibuprofen to no effect, so the pain's still there. Joint aspiration is performed, and when you look at it on a microscope, you can see no organisms or blood cells, white cells, on the sample. It's the picture of what you see is on the bottom right-hand corner. Given your findings and the likely diagnosis, what's the most appropriate treatment for this patient?
Yeah, when anyone's ready, the poll is just up right now. Yeah.
Okay, so in this patient, they're likely having an acute gout flare, and the most appropriate management is to start some colchicine, and we'll go into why in the next slide. But in terms of the features of this patient, so it's a unilateral painful knee, which kind of leads you down to thinking of, is this gout or pseudo gout? However, but you also need to consider whether this is septic arthritis or an infection in that joint. If when I was on the acute medical unit, a unilaterally painful swollen knee would usually get a joint aspiration, because then you can do the culture sensitivity and as well as look at what it looks like on the microscope. On the bottom right hand side, you can see your classic negatively bifringent needle shape, and I've got an example slide that will go through the differences. So the definition of a gout, I won't read it out, but the key learning point for this one is you use colchicine in your acute flare. Allopurinol does have a place in gout. However, you use it more for longer term management and prophylaxis. It's conventionally not started during an acute flare, so we normally treat with NSAIDs and colchicine if the NSAIDs aren't working for the pain. And after a couple of weeks, once the acute gout flare has calmed down, you can start the allopurinol for longer term protection. Note that just as a practical note, as an FY1, you can prescribe NSAIDs both orally for the systemic benefit and also topically, just so you can get some more specific local anti-inflammatory and pain relieving effect on the joint. Now, as I mentioned, your diagnosis is based on joint aspiration, and you get classically needle-shaped, negatively bifringent crystals, which we'll go through now. So this will most likely be done in the lab, and you will just get a report that says negative or positive bifringence and the appearance of, but it could come up as a pathology slide. So gout is your needle shape, and your pseudo-gout is your rhomboid shaped, and yeah, I think that's about the level that you need for your finals. Alrighty. Question number 2. Thank you for the measurement of the urate levels. Yeah, that's I think normally when we see them on the acute medical unit, when we discharge them, we just ask the GP to check the urate levels, and we can restart that allopurinol. Yes, question 2. So, a 5-year-old male presents to SDEC from GP with a new rash and painful joints. This has been rapidly progressing over the past week. When you ask the parents, she's recently recovered from a viral respiratory illness, so just like a viral cold. The rash is purple-pink, it's palpable to the touch, and predominantly across the lower limbs and buttock region. What's the most appropriate initial management of this condition? Okay, yeah, we've got a good number of answers there, so I'll move on. Yes, it's correct. It's supportive management of the symptoms. One thing to note is I've left it out of the question, but on a practical note, you'd probably want to do a blanching test on this rash, just because of where it is and what it looks like, given that it's a palpable purpuric rash, and we'll go into why. So this is likely a vasculitic Hemlock-Schönlein purpura. It's the most common benign vasculitis presentation in children, with a peak incidence in the 4 to 6-year-old age group. The exact mechanistic cause is largely unknown. However, on exams or classically, it's been tested following a viral ERT. The pathophysiology is there with immune complex deposition in the small blood vessels, causing that leak of the blood vessels, which causes that purpuric rash that you can see. You'll often find a triad of symptoms for the MLA, like arthralgia or painful joints, abdominal pain, and the palpable purpura. So that's like raised little bumps that are purple. And they might have signs and symptoms of renal disease, such as a derangement in their kidney function. However, they won't come with that if you know what, you'll only find that out when you start your investigations. Thank you for the ITP. Now, I know that most of my teaching resources in med school were on lighter skin. So on the next slide, I've got some images of what HSP looks like on darker skin tones. However, NHS England recommends that you look at the paler areas of the skin, like the palms and the soles of the feet. in case the patient has particularly dark skin. Whilst the rash is distressing, your treatment is just conservative management with rest and your fluids and analgesics. You'd want to tell the parents that 98% of children recover with no further recurrences or side effects. However, some children can have 1 to 2 further episodes, but on subsequent relapses, they tend to be less severe. Alrighty, so as promised, here's what HSP looks like on slightly darker skin tones. So, and also on the bottom right, I've tried to put, as per the NHS England recommendation, to look at the kind of soles and hands, so you can see that it's a puric palpable rash. As on the left-hand side, you can see that it doesn't look the same as the classic HSP rash that you see in the textbook on lighter-skinned individuals. Alrighty. Question 3. A 26-year-old male presents to your GP surgery with dry and itchy elbows. He's currently self-managing this with over-the-counter emollients, however, it's recently stopped working. And the itchy regions have started to spread up to his scalp. On examination, he has large, silvery, scaly plaques over the back of his elbows, as well as smaller plaques seen over his anterior scalp. During consultation, he's itching his elbows and you notice some mild bleeding over his scalp. Given the likely diagnosis, what's the most appropriate management for the patient? Thank you. Okay, yeah, got a nice split of answers there. So this patient likely has psoriasis that is not being controlled by the over-the-counter treatments, and this question was just kind of trying to tease out the additional treatment options that you have for scalp psoriasis compared with the psoriasis that you can just get on the back of your elbows and on the larger skin surfaces. Okay, we'll go on to. So psoriasis is a chronic inflammatory disorder of the skin, and it's typically described as your silvery, scaly erythematosus, and in severe flares, pruritic or really itchy and angry plaques. It often follows a relapsing remitting course, so patients will tend to describe in the history that they'll have no or very well controlled psoriasis, and after a period of stress or a period of illness, the plaque will just increase massively in size, and this can affect people's quality of life because it can be really itchy, it can cause bleeding, the cracked skin can be an entry point for infections, so you can get cellulitises and just nasty skin infections. And I've seen it in GP where their main presenting complaint is itchiness, where they just can't stop itching, and so their sleep gets troubled, and so their social life starts to become affected. I've just tried to summarize the broad strokes. So treatment is with emollients, and then following that you escalate to topical corticosteroids of varying strengths, and Failing that, you've also got things like oral supplementation and sun exposure. However, the point that I'm trying to draw out with this is that you need to apply the treatment to where the plaques are. So, for example, he's already tried greasy emollients or over-the-counter emollients, which work well for your flatter skin surfaces. However, if it's in your scalp, it's kind of hard to get lots of or an adequate concentration of the emollient into your hair. Similarly, corticosteroids are a bit difficult to apply through your hair, and so that's why if you go back, you can use things like topical steroids with the coal tar shampoo. So it's all about modifying your prescription and what the NICE guidelines say to the patient in front of you. And again, on the right-hand side, I've tried to illustrate what a scalp psoriasis looks like on lighter skin tones and also on darker skin tones. So on the top right, you can see that it does look as it's described, with scaly, silver, erythematosus with a well-defined border, and it's quite itchy. It's kind of tracking up into the scalp, but starting off not in the scalp. And yeah, I just thought I'd put a picture on darker skin, because whilst on darker skin it still looks silvery and scaly, because of how dark the skin is, you can't quite see the erythema and how itchy and cracked it might be. Alrighty. Question 4. A 45-year-old female presents to your clinic with itching. She reports that her children started school 4 weeks ago, and that they're also complaining of new itching. The itch is more predominant at night, and she reports itching over her hands, wrists, and abdomen or tummy. On examination, you can see excoriation marks with red papular marks over her wrists. What's the most appropriate treatment for her? Okay, I've got a good number of answers there, so we'll go on to the explanation. So this female, or this patient, likely has scabies or some kind of parasitic rash. And what this question is trying to draw out is what the treatment is and what advice you would give in the GP practice. So she's got new itching. The risk factors for her are she's got recent or close contact with children who are well known to spread these kind of mite-based infections, and as well as it has the typical features of a scabies type rash, with it being worse at night and worse over her hands and wrist. You might be able to see red papular marks, so that's just kind of red, small, palpable, round lesions on the skin. Yeah. We'll go on to the next slide. So scabies, it's a highly contagious skin infection caused by the mite, which is on the top of the slide. You tend to find it in the interweb spaces of your hands, so I don't know if you can see, as well as the flexures of the wrist, in your armpits, abdomen, and groin. It's classically worse at night, as we mentioned. So, and in the middle, you can see why it's so itchy, because the mites burrow into the superficial layers of the skin where they lay their eggs and they come out and eat. So the treatment is a topical permethrin, and in terms of your counselling points in GP, where you're most likely to see this, should be applied to cool, dry skin. So what I've seen before is patients have a hot bath, and then they apply the permethrin. However, that doesn't have as good as an effect. It needs to be after a bath and once it's fully dry. It needs to be applied to the whole body. Again, you need to tell them that the mites might be over the hands, but they can live everywhere. Leave for 12 hours before washing off, and they need to take 7 days of this topical treatment. Now, on the right-hand side, it's not, scabies isn't a notifiable disease, but it's a disease where you need to treat the close contacts of the patient as well. So of note, members of the same household and any recent sexual contacts. So putting my infectious disease hat on, you tend to get quite nosy with the histories. So who do you live with? What my go-to rule is, who do you share a kitchen with? And if they appear sexually active, really getting into that history with who, how many times, when, and are they also exhibiting symptoms. So the NHS or the NICE website recommends that if they are sexually active with multiple partners, you can use the sexual health services to contact those partners and advise them to also come in for treatments. Yeah, good stuff. Note that they all need to be treated on the same day, because if you have staggered treatment doses, you might have surviving scabies mites in one patient in that household. You need to tell the patient it's by direct contact, and it's really easily transmissible by touch, but also by anything that the patient touches. So things like bedding, towels, clothes, and it might seem really obvious, but you need to tell them to do a hot wash, or dry cleaning, or drying a hot dryer, or drying cleaning it. So essentially you need something really hot or a chemical bath to try and kill the mites so that they don't come back. If they do follow that, it's usually self-resolving. Yeah. Okay, final question from me, and I'll hand over to Dr. Yi. So, a 21-year-old male presents to his GP with a worsening of his acne. Over the past 3 months, he's reported his skin blemishing to be increasing in area and severity. After examining, you diagnose him with mild to moderate acne and start your topical treatment. Given the topical treatments that you're about to start, what's one important side effect to warn the patient of? Alrighty, we've got a good number of responses there. So, in this patient, we're given the diagnosis of mild to moderate acne, we're likely to start him on some adapalene or tretinoin. I'll go into, yeah. So, acne is defined as a acute or chronic condition with what you'll see in the exam is described as open/closed comedones with inflammatory papules and some pustulation. If it's really severe acne, you'll get all of the papules and pustules. So papules are just little round lesions you can feel, and pustules are filled with pus. But you also get deeper palpable nodules and cysts. But though most of the presentations that you'll see in GP and GPs where we normally manage them will be of the mild up to moderate. You will find them on the face, neck, chest, and back, and the condition affects quite a lot of adolescents, about 80%. There's no, when I was having a look through the NICE guidelines for specific definitions, they did say that it's very subjective. However, they did put guidance for mild, moderate, and severe. And so in this case, the patient was described as having mild to moderate acne. And if we look on the right-hand side, NICE recommends a 12-week course of a combination of treatments. So that's 2 treatments. There was a specific clause where it says don't start singular treatment. It needs to be a topical adapalene and topical benzoyl peroxide. Essentially, you need a tretinoin or a retinoid, as well as some kind of antimicrobial, or 2 antimicrobials in the third option. What you'll most likely find prescribed is the adapalene with an antibacterial topical formulation. So that's 2 different drugs. The question was then trying to tease out what your considerations are for adapalene. So the way it works, or the way I explain it to the patients, is that adapalene increases the turnover of your skin cells, which helps just push the skin levels, the different layers of your skin up faster, which helps unblock the different pores. However, because it works to increase the turnover of your skin, you can get some mildness, some redness and dryness, as well as a mild burning sensation. But the most important things to tell a patient when you start them on the adapalene is that because of that increased cell turnover, they're going to be really sensitive. The skin is going to be more sensitive to sunlight. So if they're going to be even more prone to sunburn and sun damage. I think what I've seen previously is you recommend the patient to just put on factor 50 every day, even if it's a cloudy day, every day for the full 12-week course. And the second counseling point for adapalene is that during this 12-week course, they might find that initially it looks like their acne is getting a lot worse, and that can be disheartening for the patient, and actually they might want to stop. However, you need to pre-warn them that it will get worse. However, it will eventually get better once they follow that 12-week course. I've had to do that I'll let the patient know about that. Yeah, okay, so those are my 5 questions. I'll hand over to Dr. Yi, if that's all right.
All right, that sounds good, Aaron. Yeah, so we just go on to the next slide where we want to start. Yep, so we have a 45-year-old gentleman who comes to your GP clinic with some numbness down both of his hands and wrists. He says that this numbness occurs from his thumb to middle finger on both sides as well. He also strangely notes that he has dry eyes, making him quite uncomfortable, despite using eye drops that have just been there for quite a while. However, on hand examination, you note a swan neck deformity on his index finger, Z thumbs, and atrophy of the femur muscles, and this is present on both sides. There are no changes to the nail beds or there are any rashes anywhere on the body. You've done a Tinnell's and Phelan's test, which are positive at this point. So, keeping in mind what the most likely diagnosis could be in this case, what sort of antibody markers should the GP request at this stage? Right, some good responses over here. So if we just go to the next slide, and that will show the answer. Yeah, so what this stem actually describes is a classic case or classic presentation of quite a late rheumatoid arthritis. And as you can see, the most likely antibody that we want to do is anti-citrulline peptide and rheumatoid factor. And I've put over here in the answers of all the other antibodies and the related conditions as well. If we just go to the next slide. from this point. The way you think about any sort of arthritis or any swollen joint, is it one joint? Is it less than 5 joints, or is it more than 5 joints? And from there, you can start to categorize what sort of differentials that it could be, and dumb down and rule out the other ones as well. In this case, because it's affecting most of his fingers, it's mostly a polyarthritis at this stage, and because it's the same on both sides, you might be thinking of a polyarthritis that's symmetrical. So rheumatoid arthritis is probably one of the top differentials from that point, and this is what you also do to describe any sort of arthritis to someone in acute medicine, to rheumatology, or any sort of specialty, even orthopedics as well. If we just go to the next one to see what I mean by those examination signs, yeah, you can see that I've quite listed out a few clinical features that may come up in an exam for rheumatoid arthritis. The ones that come up the most often that they say, and you may see in clinical practice, is muscle atrophy, which is a quite a late sign. Swan-like deformity, where you have flexion of your distal interphalangeal joints and hyperextension of your proximal interphalangeal joints, makes it look like a swan neck if you see it as well. Z-thumb basically just describes how the metacarpal phalangeal joints at your thumb are bent in a way that it looks like the letter Z as well. And as you can see, the mountain sign over here, if you ask a patient to put their knuckles together, the spaces over here are more swollen up than as usual, and that's just a sign of tissue swelling for quite a long time. And one thing to know in history that they always ask in exams, is it osteoarthritis or is it rheumatoid arthritis? And apart from being asymmetrical or symmetrical, which you can still get in osteoarthritis, the key thing is the symptoms, where osteoarthritis gets worse throughout the day, rheumatoid arthritis gets better throughout the day as well. And if we just go to the next slide over here. Rheumatoid arthritis, as you can see from this quite extensive list, is also associated with many different types of associated symptoms as well. But if you had to pick one of each just to remember, at least a bare minimum for exams, I would say amyloidosis is definitely quite linked. Rheumatoid nodules are noticeable in late rheumatoid arthritis. Pericarditis or myocarditis can be seen. Carpal tunnel syndrome, which was described in the case earlier, is very commonly mentioned as well. And when you do a hand examination, you want to also check the elbows, because in late rheumatoid arthritis, you get nodules, which are rheumatoid nodules. You can get signs in the eyes, which could be keratoconjunctivitis sicca, episcleritis if it's a bit more painful, or scleritis, which is more common and more painful. And they may get some peripheral neuropathy as a result of this in the long term. It's also associated with Felty syndrome, where if you get thrombocytopenia, neutropenia, and splenomegaly, you're more likely to forgive the specific syndrome if it comes up in the SBA. If we just go for the next slide over this bit, yeah, you can see from this X-ray over here that of those signs that we've seen, and then we just go to the next one from that bit. When you want to manage rheumatoid arthritis, you want to do it conservatively first, with patient education on what it is, as well as physiotherapy. Medical management is determined by something we call a DAS28 score, and this gives a score based on how high or how serious the ESR or CRP is for your inflammatory markers, how many joints are affected, and more holistic measures such as how painful the patient feels, or how it affects their activities of daily living from day to day. And this helps us guide what sort of medical treatment we use, which are classically DMARDs. If it's mild, which is a bit early on, we usually use hydroxychloroquine. But if it gets more serious, we start to use methotrexate and sulfasalazine, and more sort of biological agents as well, which will be highlighted in the next slide from this bit, which are just a summarize of a list, which we can get in a recording to review it and pause it here to read it more. But essentially, these affect the immune system and the cycles of inflammation in the body, and that's why it's good in treating inflammatory condition like rheumatoid arthritis. So key things to notice with methotrexate, that's why it's on top, because it's the most common one examined in exams. Sulfasalazine is known to cause infertility in males. Hydroxychloroquine is quite notorious for optic neuritis, so they would need some ophthalmology screening from time to time. Azathioprine, you need to know for exams that you need to measure TPMT prior to prescribing so the body can break it down, as some individuals don't have this particular enzyme. And other stuff like penicillamine, cyclosporin, anti-TFA, and cyclophosphamide are quite commonly used, although a bit rare due to their prominent side effects, as you can see in this table. If we just go to the next slide over there, we are going to this next question, which talks about SLE. So, out of all these points, which one of these is false regarding the condition of SLE? And remember, when you ask, it's the false answer. So one of these is not true. All right, so we're quite split on these responses, but if we just go to see what the answer is on the next slide, the answer is A in this case. That while you do measure complement protein C3 and C4 in SLE, the levels are actually low rather than high when you see the results, and everything else is quite true in SLE. It's quite a broad condition. If we go to the next slide to see what we mean. So, what is SLE? It's a type 3 hypersensitive autoimmune disease, which means you have loads of antibodies being deposited throughout many different parts of the body, causing an increase in B cells activating and T cells also going. So, you're going to have widespread inflammation, widespread immune response to areas that don't even need it, which is why it's classed as an autoimmune disease. It's quite common in females because it's quite linked to estrogen being a driving factor for autoimmunity. The mnemonic I like to use to remember the features of SLE is soap brain. So that's serositis. So any sort of inflammation of the serosa, such as your lungs or your heart, or ulcers for O, which are quite painless, and you mostly find this just in the mouth. Arthritis, which can happen anywhere. Photosensitivity, where your malar or discoid rash, which you see in SLE, gets worse from it. You have certain blood disorders as well, so you have low everything in your full blood count. Um, when you do your antibodies, your ANA and your anti-dsDNA are positive or more than 90%, very specific to this. Immunological tests, as we mentioned about complement proteins, and neurological disorders. So seizures or psychosis are an uncommon, even rare feature of SLE, but they do occur from time to time when we see in patients. If we just go to the next bit. So because of such a wide profile, your investigations are quite broad as well, from simple blood tests to skin biopsies for certain rash which may need to happen. It can also deposit in the kidneys, causing a condition called lupus nephritis, which is a nephritic syndrome underlying to lupus. So you might need to do a biopsy of that to see or autoantibodies in it. Again, you have specific antibody tests as well, but your anti-dsDNA is more specific to disease activity. So the higher it is, the more active the disease is, and it's also used to track compliance and progression of treatment that we use as well. And as I note, isoniazid is notorious not only for its profile in peripheral neuropathy for TB treatment, but it also can cause SLE, which is quite unfortunate with such a good drug and stuff. If we just go to the next slide over there. So treatments are quite broad with this as well. So you need to protect them from the sun. You need to educate them on the lifestyle with this as well. You need to, whenever they get a flare up and they present in the hospital, you give them some steroids to calm down the inflammation and some hydroxychloroquine from time to time. And then you need to use a variety of DMARD combinations, which is going into specialist rheumatological territory that would help control and maintain remission of symptoms for the future. Next slide for the question. Yeah, so with this next question, you're in A&E this time, and a 55-year-old woman suddenly barges in with panic. When she calms down, she yells at you that there is a growing dark patch on the top of her right eye that's been going on for the past few hours. She also has a headache on the same side, which she describes as agonizing. Her past medical history includes polymyalgia rheumatica, a TIA previously, hypertension, and migraines. She has no drug allergies and currently takes prednisolone, clopidogrel, amlodipine, candesartan, and propranolol. You do an examination and you find that her peripheral views are reduced in the affected right side, but the central vision is preserved and the left side is asymptomatic. She doesn't report any other ophthalmological signs. When you try to study her hand through the scalp, she just jolts in pain, said that was painful. To make sure you do more neurological examinations which are normal, and her NIHSS score, which is a screen for stroke, is 3. What is the next best management at this point in time? Just get the poll up for that. Oh, there we go. Ooh, already getting some very responses as well. We just see if one more person wants to volunteer before I move on to the answer for this question. All right, that's fine. If we just show the answer for this bit, in this case you have to start them on a high dose of prednisolone, and this decision is classically causes some controversy and some argument during medical school as you learn about this condition, but we will just cover it in the next slide. As the condition I am talking about is giant cell arthritis, or temporal arthritis as a more classic term. It's a vasculitis, which is an inflammation of your blood vessels, which happens more in 50-year-olds and above, and it specifically affects the temporal artery, which runs along your temporal bone over here. Symptoms can include unilateral headache on the affected side, scalp tenderness, which was mentioned why brushing the scalp was painful. Jaw claudication can also be seen, so when they chew, it particularly hurts on that side as well. In serious cases, you may be even seeing the swelling inflammation of the temporal artery. And in particular late onsets, like in this case, you get a condition to the eyes called amaurosis fugax, which is a monocular blindness. It classically starts at the sides of your vision and grows towards the center, which is why her central vision is normal, but the peripheries are reduced in this question. The reason why, some tips to maybe rule it out, because it could also be an ophthalmological cause for retinal detachment and stuff. However, she's already taking steroids for another condition called polymyalgia rheumatica, and polymyalgia rheumatica is very closely associated with giant cell arthritis and vice versa. So if you get PMR, there's an increased risk of getting GCA, and if you get GCA, you're more likely to get PMR if you haven't already. Going to the next question, or next slide, sorry. You want to do a variety of investigations, so you can take some blood tests to see if there's any evidence of inflammation as well. And you may even organize a temporal artery ultrasound or biopsy. A biopsy is more specific, as with an ultrasound, depending where you scan inside, the classic finding of the inflammation is that it skips along the artery is also a continuous one, just like in Crohn's disease. Therefore, when you scan a particular area, if you biopsy a particular area, you may miss a part of the artery which is affected, and that turns out to be normal. So that's why you want to scan the whole artery instead, so you're not missing anything out. But because it's quite an emergency, if you do think it's GCA by this clinical diagnosis, you want to start steroids first before you want to organize anything else, as that's a priority to save a vision and to save any of the other symptoms in the future as well. Yeah, if we just go to the next question over this bit. Yeah, so the reason I just add this other slide just to wrap up some of the rheumatology stuff is just to make you guys aware of other vasculitis conditions that can come up in exams. They're a bit high, they're a bit very, very, very high yield. Sorry, low yield, that's a very specific, but when I was doing the mock doing it, one of these did come up. So this is just a list of you guys to start to maybe read up a bit about it, just in case you know a little bit, rather than not knowing it in case a question of this sort of comes up unexpectedly. If we just go to the next slide. Yeah, and this is just a other rheumatology slide to see other rheumatological conditions that may also come up, and you may be asked to answer some of the questions. So it's worth a read just in case, if you do have the time for a bit. And we now move on to some of the dermatology. So with dermatology, you can always read this in more detail, but I've just attached some stuff to describe sort of a lesion. So I use an ABCDE criteria, which is what we use to describe it to a dermatologist or to anyone. So you have a set system. And if we just cycle through the next few slides a little bit, I've also noted some slides for what sort of these signs or these descriptions mean and when you use them as well, because they're very important for a dermatologist to determine what is what based on the description you give them, as you'll be talking to them over a phone before you send them a picture, for example. So then if we just quickly cycle through the next few slides, it's just going into these definitions of details. In a recording, you can always pause these and just see them in more detail from that way. And next slide as well is quite a bit I've put inside. Right, and just following one as well until we get to the question, I guess. Yeah, it's quite a lot of things, but take your time to read it. Now, there's a common thing you can see in GP practice. 60-year-old woman was brought in by her son after he noticed the back of her neck. It wasn't found until she went to the hairdressers for a nice little haircut when this was found. Based on just the picture, what is the most likely impression to consider? All right, so if we just show the answer right now, this picture is actually a very classic example of a basal cell carcinoma, which you can find more examples on dermnet.nz, which is your best dermatology website to get references as a tip to see. If we just go to the next slide, we just go through the description of why this is a BCC. So very common skin cancer, mostly associated with a UV exposure, like a lot of other skin cancers as well. It's asymmetrical, it's quite irregular in border, and when you see its color throughout the whole lesion, it's quite uniform, so almost the same. They classically like to describe it as a pearly white sheen just because it looks like a pearl on top and it's quite shiny as well. You can also get telangiectasia, which is a very common association with this as well. And rodent ulcers are quite a late diagnosis for it, so I wouldn't delve that too deep, but just to be aware that it can happen. Ultimately, despite what it is, if it does look suspicious like this, you're going to have to biopsy it in the end. And we could just go to the next slide. And when they biopsy it, they have a whole plethora of treatments, from medical treatments to try to inhibit the pathways that allow skin cells to multiply, classically 5-fluorouracil. You can do cryosurgery or just curettage, cautery as well. Or if it's quite severe, you can do Mohs surgery, which is removing it layer by layer until the whole lesion is removed from the core as well. Well, radiotherapy is only indicated for very profound BCC, like if it evolves to a rodent ulcer, or if it's quite extensive throughout the body, and you only need to do follow-up if it comes back again, regardless of the location. Going to the next slide, I'll be covering the other thing that causes a lot of debate, is a squamous cell carcinoma. So, unlike a BCC, although it's still asymmetrical, there's a lot more crusting to it. It's not uniform in color, as you can see. There's dark colors, there's light shades, there's red colors. You can't really tell over here. And unlike a BCC, where it's classically quite smooth on the surface, this one is quite ulcerated, so it's almost like a massive ulcer in the location, and it's quite raised on the edges as well. While a BCC can occur in areas of hair follicles, which is why you see them throughout the head, and SCC can occur anywhere, especially the lips, which a BCC can't be located. But otherwise, those two can get confused either way in clinical practice, which is why you still biopsy as a standard investigation, regardless of what you think, because the biopsy will give the definite answer eventually. If we just go to the next slide, over here, just some precursor conditions to read up a bit more in the future after this one, just for your own reading, as they do ask this from time to time in the exam. So you have keratocanthatomas, which is the top left, actinic keratosis, which will be covered in the next slide from this. The one on the top right is a keratic horn as well, and Bowen's disease is used extensively in the literature, but it basically means a very superficial squamous cell carcinoma that hasn't infiltrated past the epidermis yet. And another thing to note is that people who have undergone a recent organ transplantation are more at risk of developing an SCC. And then we just quickly go for the next slide, just to quickly go through actinic keratosis, which are these small dots which are located on follicle-heavy parts of the skin as well. And the mainly treatment for this is your 5-fluorouracil as well. If we just go to the last question for this one, which of these is not a diagnostic criteria for melanoma? Bit of a, I will have to admit, this is a bit of a harsh question, but it also reinforces the criteria inside, as it's important to know when someone's more at risk of a melanoma or not when you see a skin lesion. All right, so we got a few responses already. Let's just have a look at the answers on the next slide. Is the diameter that's less than 6 millimeters as well. And why is this relevant? Because you need to know what are major criteria and what are minor criteria, because there are points related to it. So a major criteria is 2 points that includes any change in shape, size, or color. And minor criteria are 1 points each, which are inflammation, sensation, bleeding, oozing from the wound, and a diameter of more than 6 millimeters when you see it. Combining the two, regardless, if they score more than 3, they need an urgent dermatology referral ASAP from that point. And we can go down into more detail in the next bits, which is that melanomas are malignant tumors arising from melanocytes, which is why they're quite dark in color, as they're quite pigmented. The people most at risk are the elderly, because of going through increased sun exposure over their lifetimes, as well as a very fair skin, particularly a Fitzpatrick type 1. And yes, this was mentioned in my mock SBA from once on what Fitzpatrick tail is. They are asymmetrical, they're irregular, they're not uniform, multiple dark colors. They go over time and they're elevated as well. And these require a biopsy. Now, the reason I put a picture of that nail is you do get melanoma from the nail in about 1% of melanoma patients. So it's something that you just need to be aware of. Like if someone comes in with a weird nail mark or they report it, it could be a melanoma and that needs to be investigated further. If we just go to the next bit, talking about the biopsy technique for this, ideally you would want to do an excisional technique, which is you do a elliptical cut around the tumor as opposed to an incisional bit. While an incisional biopsy is more beneficial for areas where you want the person to not look want to look cosmetically better, such as the face, um, it's not preferred as much as an excisional because you have less of the lesion to analyze and biopsy. So, which is why if you can avoid it, you want to do an excisional more. And the margins of excision dependent on the size of the melanoma, which is why diameter is quite important in this as well. If we just go to the next bit, um, once you get the sample, a way to assess the severity is something called the bristle thickness, which is the extent of depth of the melanoma. Um, the higher the bristle thickness, the higher the stage, the worse the 5-year prognosis would be. And if the depth is more than 1 millimeter, which is basically a stage 2 or above, you would need to do a sentinel node biopsy just in case it metastasizes to the closest lymph node there is to the site of the melanoma. If we just go to the next bit for this, common areas that melanoma can metastasize to late stage is the brain, the lungs, the liver, the and the bone as well, which is why patients with melanoma, just to be aware of in case they develop headaches or jaundice or breathing problems, you might want to do further imaging just to see if there's any metastasis. But the mainstay of treatment, if you catch it very early, is surgical excision. As you catch it early, you have almost 100% survival prognosis in 5 years. So you'll want to do that. Otherwise, it might go through chemo, radio, immunotherapy, and that complicates things. So just the next bit over here. That's a fun little image I wanted to add because sometimes pigmented BCCs can be confused as melanomas, but you can see that there's a pearly white sheen on top of that, which makes it more likely to be a BCC than a melanoma, but it's quite a hard diagnostic factor, so you want to biopsy it regardless for that. If we just go to the next slide.
Piece. I will just give him a moment. Alrighty. So this is the key slide that he has kindly put on in terms of what kind of dermatology type questions you tend to get. As you can see, it's quite a wide range, and from what I remember in the MLA, there weren't too many pictures. It was more based on the descriptions of what it looked like and where it was, as well as the kind of risk factors that the patient was presenting with. We're back.
Yeah, I'm back.
Right.
Yeah, sorry, hospital Wi-Fi.
That's
Yeah,
all right.
sorry, Aaron, continue. I think you were mentioning something.
No, I was just talking through your dermatology list of conditions and how I think in the MLA there weren't very many pictures. It was just descriptions. But if you want to
Yeah.
add, do you want me to go back to this one? There you
I was just about wrapped up with that one actually. I was
go.
going
That's all
to
right.
see that one, but you're absolutely right. It's like the dermatology conditions that were mentioned annoyingly were descriptions rather than pictures. Yeah, so that's just the unfortunate thing. But pictures will appear more often in your OSCEs, which is why it's
Yeah.
also noted to learn through those as well.
And
Yeah,
in real life, dermatology tend to just try and get you to take a photo of it. So yes, I know we have an app at My Trust that's like a secure messaging app for
yeah.
just photos like this. So yeah, I would many a time have I fumbled a kind of description, and dermatology have just said, just send me a photo, it's fine, don't worry about it.
Yeah, the roasting is normal unless you want to go into dermatology because they the terms and descriptions they use are very different to the rest of medicine. So it's just
Yeah.
a commitment to learn it and stuff.
Yes, and those slides you had previously with all the descriptors were really good. As you can see, I've turned into quite a somewhat lazy acute medic and just kind of went pustules. I think Paul had a question. What's a CAA station? I'm not familiar with that. Is that like an OSCE?
Sorry. What did he say? I'm trying to reconnect to the chat. What type of CAA station might involve OSCE
OSCE, yeah.
station?
Yeah.
I guess one of them would be the most straightforward one I can think of is you're a GP, or you're thinking you're a foundation doctor in GP, and you'll be asked to review a skin lesion, and you might be asked to take a history or something, and you get shown a photo afterwards and asked what you're going to do or what is it most likely to be. You can also get it in A&E as well for particular dermatological emergencies like eczema herpeticum and erythroderma, which I forgot to put on this list as well, but I'll spell it out for everyone else in this chat. That's just when you have widespread rash covering almost your entire body, and then you just get dehydrated from it. Yeah.
Yes.
So you do get it in
Yeah.
emergency as well. I don't know if you want to add anything to that, Aaron.
Yeah. Speaking of erythroderma, I thought that it was a rare thing until I had to manage one or two on my vascular ward
Yeah.
from drug reactions, and I think the definition in my head is if it's erythema over 90% of the
Yep.
skin surface. Um, yeah,
It's
it's quite scary.
Yeah,
And,
I when I was a final year med student, there was a man that came over. He's known to have atopic eczema, and he wasn't very compliant with his treatment. So he just let it all grow through his entire body, and yeah, he wasn't in a good shape when he turned up to ED.
good in terms of like any improvements that we can make, anything that went well. It's just good for our portfolios, and thank you for your time. We'll stay on for a couple more minutes, but if there's no questions, we'll probably just disconnect. Yeah.
Mm-hmm.
Alrighty. Yeah. Thank you
Yeah,
so
I think.
much. Yeah, that's really
Thanks,
appreciate it.
guys. Yeah,
All
I
right.
think.
See you guys.
Yeah. See you
See
guys
you
soon. I
next
think.
week for the next session.
Yeah, I think like derm and rheum are just so complex to learn and everything. So yeah, I think it's just something like this, just to try to simplify it, as a jumping point to go into it and stuff.
All right. Thank you so much. Yeah. See you guys next week.